for today, and for today's video I will be performing to you on how to monitor, assess the respiratory system and the respiratory examination and its management of a pediatric patient. The purpose of this assessment is to help the nurse to assess and monitor the respiratory system and to obtain baseline data to have an accurate assessment. So, the nursing assessment monitoring are contains of two parts, the physical exam and the non-invasive monitoring. So, in respiratory exam, this exam is going to be made of three key parts: the look, listen, and feel model. So before we will start, we will know the different terminology. Tachypnea, fast breathing rate. Bradypnea is the term used to describe a low breathing. Apnea describe the patient is not breathing at all or has a respiratory rate of 0. Dyspnea, a respiratory distress, speaks to the patient difficulty in their ability. The first thing we need to do is to do the hand hygiene. Good morning, I am your student nurse for today, and today I'm going to assess your respiratory examination. So now let's go to our physical examination. The first step is to look the appearance of your patient. You can always gain a great amount of information simply by looking at the general appearance of your patient. So the first thing is look for breathing effort. Do the child look calm and comfortable? Are they in position or where they're trying to put themselves in order to breathe more easily and comfortable? Next is to look their face. Are they look afraid? Are they having a hard time, or not responding to you at all, or are they irritable or restless? So all of this can indicate that they are not effectively breathing. Another one is the skin color. You have to check the overall skin color. So in checking the overall skin color, you have to look at it from upper to lower part of the body. So, does the patient look pale? Are they mottled? Or do you even notice some cyanosis or bluish tint around her lips? And you may notice these things around the lips are known as circumullar cyanosis. You may also see that also look their feet, their hands. If appear a little bit blue, that indicates that they don't have enough oxygen. So far, the patient doesn't have signs of cyanosis or bluish tint in her lips, and her feet is normal, no signs of cyanosis. So the next thing you have to look at a child is the trachea, which is located in the midline in their neck. Assess and make sure that the trachea remains in the midline of the neck position. So if the trachea has moved to either side, that could indicate that the patient is experiencing a pneumothorax. The next thing you have to look is the respiratory rate. Simply by watching the patient breathing, and what to do is to count for a minimum of 30 seconds to see how many breaths the patient will take. So let's count. It is very important to count for this long because infants and children often have some variation in their respiratory pattern. The normal rates for patient as follows: newborn, breathe between 30 and 60 breaths per minute. Young children, it should be about 20 to 40 breaths per minute. Older child, anything from 15 to 25 breaths per minute. And For the adult patient, it is between 12 to 20 breaths per minute. So in looking the breathing pattern, you have to see if it's regular or irregular. See the patient or a nice steady rate, even if it is fast, or are they taking very quick breaths, then they are having pauses in their breathing. Next is we will look for if the child is experiencing any drainage from their nose or mouth. Next that we will look for our patient is the difficulty of breathing, or we can call this as the signs and symptoms of a respiratory distress, wherein the patient are using an extra muscles or ways to have that solid breathing pattern. The first and most common thing that we see in children is something called nasal flaring. This is when you will see the child's nostrils actually flare out and in as they try and take their breaths. Hand bobbing, common in babies. You will actually see their head bob back and forth as they try and take their breaths. This indicates an extra effort in their breathing pattern. Another one is the retraction. Retraction are the next thing you want to be aware of it. It is the skin pulling from the outer walls in towards the ribs. You have retracting of the upper part, middle part, or lower part of the chest. Chest rise and falls as they breathe. You should see that the patient is having equal expansion on both sides of their chest as they take a breath. One side is rising more than the other. This would indicate as a problems and need further investigation. Second part of to listen to the patient. Place the patient in an optimal position to prevent crying, or any position that they are more comfortable. So in this part, to use a stethoscope to auscultate, but for now we are going to listen to the patient without an stethoscope. In listening, there are a few things that we could be able to listen. First is the stridor. So the stridor, this is known as a high pitch noise that is heard as the patient takes their breath in. If you hear stridor, it often indicates that the patient has an obstruction somewhere in their upper airway. So far in this patient, I could not hear any stridor sound or high-pitched sound. Then the other one is if there is an upper airway congestion. So you will hear the noises around the nose of the patient, throat, or are they coughing a lot? All of these things could indicate that they have stuffiness secretion collecting in their airway. So the next thing you will assess if the child is coughing. So it is very descriptive. If the child is producing sputum, it is very important to collect it as a specimen to help the provider to diagnose the patient. Now we're going to auscultate our patient using by an stethoscope. Lung has a number of areas that you must have to focus on, but the most important thing is to remember is that you always compare the right side to the left side and make sure that to listen to both the upper portion and the lower portion of the lungs doing the Z pattern. So the first that you're going to listen is the wheezes. A wheezes is a high-pitched noise that can be heard on both inspiratory and expiratory breaths. If the wheeze is heard, it indicates that obstruction in the upper portion of the airway, and if it is in the lower portion, it can indicate that there is a lower airway obstruction. This is commonly heard in asthmatic and bronchiolitis. The second one is the coarse sounds. When the patient has secretion or fluid buildup in the lungs, this generally indicates that the patient needs to cough or if they have endotracheal tube, you may need to suction them. The third one is the crackles or rills, often heard in the lower portions of the lungs, so it indicates that there is an extra fluid or friction taking place in the lower portion of the lungs, and usually associated with pneumonia or pleural effusion. These sounds can all be heard on both inspiration and expiration. So the last part about the palpation. So in this part, you're going to feel the patient doing the tactile primitus. This procedure is you're going to put your right hands and left hands both sides in the chest wall of the patient, and while they speak, so you have to feel the tiny bubbles in the chest wall of a child, and you can call it as a crepitus, a very well specific something that happened or occur in the air that develops under the subcutaneous tissues of the child's chest wall. And for the management, I'm going to perform the nebulizer treatment. Start by cleaning your hands, soap, and water. Put non-sterile gloves. Disinfect the table that you're going to work. Gather all the supplies you need: the nib machine, the mask, the nib tube, and the medicine. Position the patient while attempting to provide him or her with as much privacy as possible, given the urgency of the situation. Explain the procedure to the patient. Encourage the patient to assist in the procedures as much as he's learned self-care skills. Review the individual health plan and or the healthcare provider's order. Sit up and plug in the nebulizer machine in a location where the power source is close to the comfortable location for the medication to be administered. Unscrew the top of the nebulizer cap. Add medication into the bottom half of the nebulizer. Screw the top of the cap back on. Attach the tubing from the cap to the nebulizer machine and the cap to the mouthpiece. Turn on the machine. A mist of medication should rapidly appear. Ask the patient to take normal, slow, deep breath. Be sure to upright the position of the patient. The cap may require stopping on the sides toward the end of the treatment to optimize the completion of the dose. The treatment is complete when there is no more mist from the cap. This usually takes to 10 to 15 minutes. Turn off the nib machine and disconnect the nib tubing from the cap. Rinse the nebulizer mouthpiece or mask under warm water. Shake off the excess water and place on paper towel to dry. Wash your hands after the treatment. Document the intervention and outcome in the patient healthcare record.